Good afternoon. Hi, everybody. This is Mayur. Narayan. I'll be serving as a moderator for this session. I'd like to invite Dr. Ridwan Shabsigh to join me on stage as helping me moderate the session, as well as Dr. Stephen Carroll. He's gone. Perfect. So we have two of us who will help moderate. If not, I'd be happy to do it. We are going to open the trauma and acute care surgery session. We are running about 30 minutes behind. We'll make up some of that time in the break. So as we transition between the trauma and acute care surgery session and the surgical oncology session, we will move straight through. For those who need to step out, please do. It's my distinct pleasure to introduce somebody who I've known for quite some time and have followed his career, storied career. This is Dr. Rhee, professor of surgery, City University of New York, of course, Uniformed Services University of Health Sciences. He's a decorated military veteran. He's going to be speaking to us on changes in U.S. trauma, the big picture, and changes needed in our headings. Please join me in welcoming Dr. Rhee.
I don't know if it's a good or bad thing to be talking during lunch. I know it's bad to be doing it after lunch. And this is probably not going to be a fun, exciting talk with a lot of videos and movies, and many of them will dry to some people, except one of our audiences here is in global health. So it's interesting to see. So, you know, the trauma world is changing quite a bit. And one of the things I've been learning over the last decades is some things you shouldn't do in public, and that includes saying what it used to be. And as I'm getting older and older, that's getting harder and harder to do as we talk about what I could do, what it used to be like, and actually as to why I got into trauma to begin with. I was in the Navy for 24 years. And my interests in trauma was basically related to that. And one of the things we can't also do is ignore the changes, whether we like it or not. You have to be aware of these things. Whatever you tell anybody, I already knew that. That means that you've already closed your mind, and you're not going to listen to anything else or the way it's being presented. And then finally when you say it's impossible. Well, then at that point, you've already given up, and you're not even going to try. And while this is an old-fashioned, you have to think about being old-fashioned in many ways to think about the change in trauma, because it's changed so much. I'm not quite sure if this is the job that I signed up for. So this is a population pyramid started in the early 1900s in the United States. And if you've seen these population pyramids, I think you guys know that this is dramatically different today than it was before. We had more young people as older people died. But as medicine has been improving and we're doing anything changes, this is no longer the case. So if you look at Canada's population map, it's also similar to this as well. This is not a U.S. phenomenon, and they combat some of this stuff with immigration, for example. You need working laborers when you're not making kids. Although we're not in farms anymore, we still need to have kids. That's why I think everybody also knows the tragedy that's going on in Korea and Japan where people said, you know, I'm not so crazy about having kids anymore. So this impacts us tremendously as well as our population changes. You know, over 100 years ago, the number of people greater than 65 was very small, and now it's gone up 5 times what it used to be over 100 years. I was born in the 1960s, and we were at 3 billion people at that time. And if you go back 100 years to the 1860s, we were at 1 billion. And it took about almost 100,000 years to get to that 1 billion. But in 100 years, we're now at 3, and now we're obviously approaching 9. All in my lifetime. So the population has really changed. And a lot of the data I'm going to show you, I'm going to say this up front, my data ends at 85. Because when we came up with these databases, people didn't live past 80. Now you look at the databases, it skyrockets after 85 because they clump everybody into above 85. So the last several years of papers that I've been writing have been to point this out that we need to redesign our database. Because when I get 90-year-olds and trauma patients, and you intubate the 90 patients, how many come off the ventilator? You know, my experience is 0. You could do it for elective surgery, but the thing that's, you know, and then just trickle to trauma, it's terrible. And this is important because old people don't do as well. You know, when I was in LA County doing trauma as an early part of my career, or Washington, D.C., you could take those guys and you could do just about everything you want. You know, an incision from the neck down to their knee, survive anything and everything. But now with our elderly population, they're very fragile. And actually, the last 15 years ago, 15 years or so, the one thing I never thought had become popular or famous for is frailty scores. You know, so that's become a huge part of our lives as well. So, Dr. Shabsigh, this just got published and it's got our institution's name on it. We'll be able to use it for a verification process. But this one is called Evolving Epidemiology. I got an MPH from Seattle, Washington, so I actually got to use my degree in calculate epidemiology. So this is just coming out. It's online now. You can get it online. And it follows up on the other paper I wrote about a decade ago called talking about increasing trauma deaths in the United States. It's actually one of the most referenced papers I have in my repertoire. So this just goes on to do this, and I'm doing this every 10 years. I might be able to write one more. And the reason why is because at the turn of the decade, we had new data that's only available at that time period, which is the census. So we used the normal types of databases, and mostly CDC database, but the difference is instead of having a suspicious guess at the population, we just used official census data. The census data only comes along every 10 years. The definition of trauma is a little bit problematic as well. So these are the list of things, I'm not going to go through with it, but suicide, homicide, poisonings, and so on. This is the World Health Organization definition, which is really problematic in some ways because as the United States has now a well-developed trauma system to talk about death, it also includes poisoning. And I don't think that's something we would normally count as that. But if we're going to compare apples to apples and compare rates to rates, then we have to be stuck with the official definition, which includes poisons. And I mention that because anybody who's been watching the news knows about the opioid deaths and the fentanyl deaths, which are, you know, which are almost reaching 100,000. So I wanted to compare that to two of the most funded areas of medicine, which is heart disease and cancer deaths, and compare what we're doing with trauma. Is this something we need to pay attention to? And how are we doing with the other areas which have been heavily funded for research, therapy, and prevention? So what we found is that compared to 20 years ago, first of all, we have 268,000 deaths per year, which is listed as trauma. That's the highest ever reported in the United States, but that's probably because the United States has more people than it ever did before. But there was a 91%, this represents a 91% increase in trauma deaths. I think if you went from 13 to 18% or something like that, you'd be worried, but this is a 91% increase in trauma deaths. And the population only grew 17.8%. So this is disproportionate. So this is what took me lots of years to generate this graph. The blue lines are 20 years ago, the yellow lines are 10 years ago, and the red ones are now. And what we originally described was a high modal distribution of young, 18, 19, 20-year-olds, risk takers getting killed, people in the baby boomer ages, and then finally the elderly. And this one is an example. If you listed greater than 85, that thing would skyrocket because there's so many people listed in that group. So this was an issue for me that I had a hamper over for a long period of time because I knew that the data that derived this had poisons in it. So to go back and to pull out for every age, every single year, the number of people that died from opiate deaths, which includes the fentanyl, I had to end up doing that, and this is the results that I'm going to show you. Now, the trimodal distribution of death has shifted, as you remember, from the left to the right. They're getting older, and the causes of death have shifted as well. So this is the data now with the opiate deaths out. Okay, so all the poisoning deaths, most of those are out. And if you compare the two side by side, the patterns are still in existence. There's a big rise in trauma deaths, and also the shift is to the right. So it didn't really change that much. But, you know, the main point of this wasn't to show how many people just died from trauma, but you got to be able to compare the rates. And again, these are the rates with and without the opiates in it. But you see that the red ones, or which are now, the death rate is actually worse than it was before. We're not really improving, we're actually getting worse. If you look at what caused the death, these are the main variables I look at: car accidents, firearms, poisoning, and fall death. What we find is that the overall death rates are increased, but in the car accidents, actually it's not so bad. It's actually decreased. So cars are getting safer. We're obeying more laws, and I think everybody who does this for a business will tell you that's true. The bad car accidents are not coming in anymore. But the firearm deaths are increasing about 30%, and the fall deaths are also increasing. And this is now because of a different definition of fall and drop. For me, a fall was someone falling from a height, a bridge, or something tall. Not at all. But now, you know, if you slip on the way to the bathroom in the nursing home, those ground level falls are coming in as trauma. You know, and then there are another ones that they hit their head on the pillow, and they're becoming trauma patients as well. So overall, basically, this was summarizing the table that I just showed you, that it has increased from 50 to 81 in 2020. Car accidents have decreased, firearms are increased, but poisoning is obviously tremendously increased. And we all know the issue going on with the fentanyl death. And if you look into that topic, how it's made, how it's smuggled over here, it's fascinating. And I don't think no matter what you do and how authoritarian you are or how much military you use, this is going to be an issue unless we actually know how to decrease the demand. The demand is there. As long as there's a demand, human beings will figure out how to get it to you. And they don't know. In the United States, that's what we want. And the crazy thing is that the kids know that it's going to kill you and you're going to stop breathing. But if given a choice, they want the good stuff. And good stuff has fentanyl in it, and that's why they're going for it. So the population has changed, and this looks at the rate of change for every age group. I won't go through it to you in detail. The blues are a comparison of 10 years and so on, but the grays are the difference between us now versus 20 years ago. So you see those gray bars, you see that some changes to the right, in the middle years, to the teens, to the 30s, less number of middle-aged people, but those baby boomers are really staying way out there to the right. Now, if you look at the heart rate, heart deaths and cancer deaths, we have a lot of room to be proud. All the work that we've done has paid off. Billions and billions and billions of dollars. Hopefully, Elon Musk will come after that. But I think this is just proof that with all the money and research they put into it, because my first grant that I got in the military one of the uniformed services, came through the prostate cancer rates, because the second most highest paid research item in the military at that time period was breast cancer. I don't know how many active duty military people have breast cancer, and nor do they have prostate cancer. But guess who has breast cancer and prostate cancer? The congressmen and the senators. And that's where they're putting money into. And they actually have time to go searching for that money. So, trauma death rate getting worse. Now, if you put all four of them together, so we have population, the trauma deaths which are falling way to the right, which is bad, and then we got cancer and heart disease, which is going to the left, which is good. So one of the issues is the way CDC sort of tabulates death. So there is no such thing as death from old age. In all the listings of death, natural cause and old age is not in there. However, if you go to a nursing home and someone is dead, and we've all filled out those death certificates, you know how inaccurate that they are. Because we fill them out and they take our word for it. And the vast majority of those deaths are listed as heart disease because their heart stopped when they die of old age. So that number is even more skewed. So cumulative deaths, trauma is the leading cause of death until age 67 when cancer takes over. And as you get older and you get to this stage, we have more mutations in our body and cancer takes over. In regards to heart disease, it doesn't take over until age 69. So these are the productive years, the taxpayer years. So by 2020, trauma was the leading cause of death up to age 50. In the literature, every trauma paper I read used to say trauma was the leading cause of death to age 44. And that's because they were just looking at the raw CDC data, which went from 35 to 44, and then 45 to 54. But I did it by every year, and we showed a change to 46 10 years ago. Now trauma is the leading cause of death until age 50. Trauma remained the leading cause of cumulative death up to 67, and primary contributor was the primary contributor to years of life lost because it affects the younger people because of cancer and heart disease. Cancer and heart disease showed a decline, as I mentioned, and of course the largest increase in trauma deaths are baby boomers. So this is the part that, you know, I'm trying to sneak in there under the paper. Death rates from cancer and heart disease decline is essential to reprioritize. This is political language, obviously, to really allocate. We need to shift the money over to trauma. And when we talk about trauma and epidemiology, I'm just going to mention two other papers that we wrote, which is that it's not an epidemic, okay? Epidemic is different than endemic because in the United States, it's there year after year. So COVID is an epidemic, okay? When it goes around the world, it's a pandemic. But since we have gunshot wounds every day in our lives, firearm injuries are endemic in the United States. So this is the same kind of stuff with the CDC data and looking at firearm deaths. This is only up to 2018, and it's the #1 years of potential life lost because it affects so much of the young. So when we looked into this more carefully and just jumping to the punchline, suicide in white males, that number is just going crazy. Homicide in black males is high, but it's not changed over time. And as a result, bullets are now the leading cause of years of potential life lost in trauma. And firearm deaths overall has taken over car accidents. Now, if you look at this, this is complicated, but it looks at the different age groups with the number of deaths, and then over the years, and you'll see that in that population of people who are susceptible, this group and this group, it is that in that group, but as this group gets older and older, there's a significant amount of deaths. And actually, this group here also is highly significant. And there's a ton of very older people that are dying by bullets. Anybody know why? Yeah, they're not getting robbed. Okay? It's their right to have a gun, so that's what they do with their guns. And now, if you look at the years of life lost in doing these calculations, bullets have taken over all the other sources. And of course, we sort of know why, because in Korea, I helped start the Korean trauma system, because they don't, general surgeons who are typically the ones who become trauma surgeons, in Korea, they don't want to do trauma at all because the national healthcare system, so there's no pay difference, number one. Number two is non-operative. They rarely have to go in and take a spleen out, especially with the angiomodulation nowadays, right? And the reason is because Korea has zero, not one, but zero bullet wounds a year. And that's very similar for Japan as well, except for an occasional assassination. So this is just one of the main points that we're blind to. But if you look at the suicide, and again, this is another paper that's the same kind of thing, because bullets have now taken over car accidents. And if you look at who is doing this and why they're doing this, it's because of the suicides. So the homicide rate, little increased, I would admit, whether it's significant or not, but this is the suicide rates. Okay, people are putting a gun to their head, and the success rate of suicide attempts for bullets with a gun is pretty high. It's over 95%. Whereas if you try to do it with pills or with hanging, it's nowhere near as efficient or efficacious as that. So this is the rate of reduced life lost, and who are these white males? They're basically baby boomerish. If you took a snapshot of NRA, that's the population of people. So again, talking about the difference between car accidents and bullets. So that's the changing epidemiology we have in the car. I've been told I have 2 minutes, so then I will say I can beat that by 1 minute. And as we ask for money from the cancer world and the heart disease, I know it's going to be a tough job. But thanks for your attention.
Insightful talk. We'll hold questions until the end, so we'll continue.
Yes, thank you. We introduce now Dr. Shabsigh to present on pelvic fractures, stabilization and hemorrhage control in trauma. Dr. Ridwan is an attending trauma and acute care surgeon, program director, surgical critical care fellowship, associate program director, general surgery residency, director, director surgical research and surgical simulation, Grand Medical Center. Dr. Ridwan.
Good afternoon, everybody. Thanks for the opportunity. Thank you to ICS. So I work in a hospital nearby, not far from here. It's in Myrtle Beach. It's like 2.5 hours from here. It's a level 1 trauma center, and it's one of the busiest in the state of South Carolina. And when Rhee asked me to talk about something which is as vast as pelvic fracture, I thought like it's very difficult to finish within 12 minutes. But I'm going to talk about only the salient points, and hopefully we're going to finish in a few minutes. So pelvic fracture, I have no disclosure. Only thing is that like this is a multidisciplinary approach to pelvic trauma management, and I'm not an orthopedic surgeon, nor am I a vascular surgeon, nor am I a physician. But I'm an old school trauma surgeon. So we're going to talk about a few selling points. We're going to talk about those in a few minutes. So this is like one of the things that we're going to talk about. The diagnostic tools necessary prior to the basically what are the investigative tools we would order once the patient comes in with a hemodynamically unstable pelvic fracture. There's another one, the role of pelvic binders in a hemodynamically unstable pelvic fracture, the role of revor in those cases, which patients require preperitoneal packing, which of these patients require external fixations, and which patients warrant angioembolization, indications of definitive surgical fixations in this severe pelvic injuries, and ideal time window, when should we go in and fix those. This is the one like we collaborate with orthopedic team and the intensivist. So we start with the World Surgical Society of Emergency Surgery classification, and they divide pelvic ring fractures into essentially three parts: minor, moderate, and severe. Since this is a global conference in its entity, we're going to talk about mostly this WSES. Not going to talk about individually about the Burgess classification or the Times classification. We will include those in our classifications here. As you can see, the minor ones are the ones which are hemodynamically and mechanically stable, and the moderate ones are hemodynamically stable but mechanically may not be stable. And the severe ones are they're both hemodynamically and mechanically stable, and sort of crashing patients. Again, for completion, I'm going to include this Burgess classification and later on the Tiles classification, and we're going to show you a snapshot of the top one is lateral compression fracture, the three gradings of it. And the gradings are important because depending on those gradings, we classify into the WSCS level 1, 2, and 3 are minor, moderate, and severe ones. So this is the classification I've included it for completion. Again, this is a recap of the one I mentioned before, the WSES1, which includes anterior compression fractures 1 and then lateral compressions 1. So they are usually hemodynamically stable pelvic fractures. And the moderate ones are grade 2 and grade 3. They are the ones, as you can see, the grade 3 includes the vertical shear and the combined ones, and they are usually hemodynamically stable pelvic ones. And then the severe ones are the hemodynamically unstable ones, and they are the grade 4. So recommendations from the diagnostic tool. Again, this is something which is like varies from hospital to hospital, in which hospital you're working, and the resources that is present in those hospitals, and the facilities which has IR facilities versus specialized orthopedic trauma facilities and vascular specialties, how available they are, how readily they are present. Those are the things which varies from place to place. These are the 7 points that I'm going to talk about. Obviously, the time between arrival to the emergency department and the definitive bleeding control has a significance in those unstable fractures with pelvis. Pelvic fractures, as we all know, have significant association with other injuries, severe head injuries, severe thoracic injuries, and a large part of them has significant mortality on the scene. And of all the people that end up in the ED, like 15 to 20% of them end up with presentation of shock. And of all those presentation of shock, right about like 30 to 35% of those patients die from those injuries. Serum lactate and base deficits are markers of airborne surface resuscitation, has been used. So we follow the ACLS trauma protocols here in this hospital, everywhere in this country and worldwide now. So anybody who is hemodynamically unstable goes through the primary secondary surgery, as you know, for the junior ones. And we add a chest X-ray and pelvis X-ray and a knee fast exam as an adjunct to the primary surgery. And so, as you can see here, pelvic X-ray and EFAST are recommended for those unstable fractures. And early pelvic stabilization along with early angiography and rapid reductive maneuvers and of course, if the patient requires laparotomy are grade 1 evidence. Multi-phasic CT scans, everybody these days, like anybody who walks through and is able to go to a CT scan, gets a CT scan is part of the ABC is part of the CT scan. So this is a cartoon which shows a picture of the pelvis. A pelvis is a place where you can accommodate almost up to like 3 liters of blood, and you can, if you are not careful enough, you can lose about like a liter of blood in and out. So our job is to basically make this, if it's an open book or you have enough space, you have to make it smaller, so that like either by using external fixator or by binders and make this a smaller place so that it will lose out and expand from this. 3D recon is more from the point of view of orthopedics, reconstruction and operative interventions, but it is helpful for them. But most of these pelvic patient injuries have like injuries to other associated organs. So careful examinations of the pelvis, of the rectum is of significance. You should do, if you're concerned about them, if there's like hematoma in the scrotum, penile hematoma, blood in the neopus, you should be careful about checking them all out. And retrograde urogram or retrograde cystogram is of significance. If you're concerned about a perineal injury or rectal injury, digital exam is of significance. And a proctoscopy is indicated if you're concerned about those or suspicious about those. Next one is our, it's an algorithm from the SES. The multiple algorithms, I have a couple of algorithms from shock trauma and my later study, but I'm going to talk about this one. So only the part, as you can see, it mentions both stable one and unstable one. So I'm going to go over my right side part. As you can see, like obviously when the patient comes in, you go through the primary and secondary protocol. If you're simultaneously we start with resuscitation if the patient is unstable. Initially, our aim is to do damage control resuscitation, if that is possible, which includes resuscitation with blood products and MTP as indicated. You have to use TXA if the patient is here within 3 hours. ABG helps in our, as you can mention, like we mentioned about base deficit as an end product for resuscitation. And if those patients have severe lesions, you have to be careful about ruling out other injuries also, and those are the ones which are not causing the hypertension. And pelvic binders, preperitoneal packings, and then all the REBOA as an initial maneuver, and also angioembolism are of significance. If the patient is stable, they can go to CT scan. If not, they will go to OR and do a laparotomy. The importance of the laparotomy, sometimes you can do pelvic packing, and you don't have to basically you can have a separate laparotomy incision that stops before your pelvic packing incision, and that does not hamper with your tampon effect. Role of pelvic binders are hemodynamically unstable ones. So the cartoon I showed before, it shows that the pelvic binder is a temporizing measure. And in fact, we do it on an outpatient, on an outside facility by EMS also, while they're able to do it and at least try to reduce the volume and the volume of bleeding. You can use a sheet, and it has to be in the level of the greater trochanter and symphysis pedis, and or you can use a binder in the hospital. These are some of the images of the pelvic binder using a sheet or specialized binders. It can be various modifications of those. In pregnant patients, you can have the adductions of the leg, and that can reduce the volume. Elderly patients also benefit from those significantly. Role of pelvic binders, as I said, like um, it has to be done as quickly as we can so that it reduces the volume. At the same time, like you need to be careful to remove it, like when the circulation is done, means like because it can potentially cause pressure necrosis. And so whenever the patient is being resuscitated and taken to another facility for laparotomy or injury, so we need to get rid of those. Resuscitation, thoracotomy, and robo. Robo was like started way back during the Korean War, but it has gained prominence and is almost at par now with resuscitated thoracotomy in the ED, and it has been significant armamentarium in our trauma ward. So unstable pelvic fractures, if they're isolated unstable pelvic fractures, they can benefit significantly from introducing a robo in zone 3. If you are still unsure about the exact cause of the hypotension or the stage of shock infection is an extremis, we can start with the robo in zone 1 and then come down when you eliminate the other causes and with pelvis as the sole cause in zone 3. There have been uses of partial robo or intermittent robo, and that has decreased the occlusion time and the ischemic insults in some cases. I have limited experience with those. Again, here, robo does eliminate the systolic blood pressure in patients in extremis, at the same time preserving the carotid and the coronary blood flow. There have been recent studies which shows the beneficial effects of those. And zone 3 robo and the partial robo and intermittent robo have significant positive effects on the survival rates of those patients in extremis with significant pelvic fracture and unstable hemodynamics. This is a pattern showing the profuse major blood supply in the pelvis and their effects in hemodynamic instability. So this is a placement of a robo here in the trauma bay. So normally we do a robo in the trauma bay, and then we took x-rays, and if the patient is an extremis, comes in with extremis, some people, if you're concerned about a pelvic fracture, you can put in a robo as a first maneuver, like after you do your primary survey and your adjuncts, and you can put in and then you can use them when appropriate. But it does have its own complications also. It has to have like people who are good in those getting articular abscesses. It can cause significant damages if you're not careful. There have been higher incidents of vascular injuries to them, and if you're not careful, you can have thrombosis of those vessels. You can here see thrombosis of those vessels, and even I remember this patient had eventually a below-knee amputation from this. Again, as I said, importance of placing the robo in the right place is of significance. So this is a zone 2 robo which was inappropriately placed, and this is another one which is like near the bifurcation, and all of those has catastrophic implications if you're not picked up early. This is the robo we use. This is like some of the pictures of the ProCat, the intermittent robo, which decreases the ischemic time. So nowadays, like most of the hospitals in level 1 centers and even level 2 centers have like been trying to develop the endovascular hybrid ORs, where multiple specialties can work simultaneously and help in the management of the patients. Preperitoneal packing is of significance. So as I mentioned briefly previously, preperitoneal packing helps, and you can, it's done within like 10 minutes under proper cases. And you can have a separate laparotomy which stops before it, so you don't hamper the compound effect of it. And pelvic packing performed in conjunction with pelvic stabilization helps in minimizing bleeding control in all cases. So these are like some of the pictures of preperitoneal packing. It can be done in the ED, the trauma bed, or it can be in the OR in controlled situations. Again, so these are like some of the ones where you basically put in the preperitoneal space, make a small incision from simplest from the intraumbilical region, and pack in the space of access. 3 on either side. You can use combat balls, you can use lap pads, but it definitely helps in tamponizing this. Because most of the bleeding in these scenarios are, almost 80% of them are venous in origin, and around about 20% of them are arterial. Again, as I said, like pelvic fracture related hemodynamic instability, persistent bleeding, even after angio, should always be considered for preperitoneal pelvic packing. There are like some cases which patients have already undergone prior anterior C-temp fixation. They also can have beneficial effects on those patients. There's a cartoon showing significant pelvic hematoma and the bladder, and you have your dissections done already by the hematoma, and only thing you have to do is like go into that space and then pack it, and it helps. It definitely helps in temporizing the bleeding. The role of angioembolization, and that is a role with a proper hybrid OR, and that helps significantly in a situation like this if you have the facility. Effective measure of hemorrhagic control with arterial sources. If you have a blush in the CT scan, the patient is able to go for a CT scan area blush and or extravasation, those patients will significantly benefit from them. And remember, like those cases also will benefit from the pelvic packing, because in the case which have a pelvic hematoma volume of 500 cubic centimeter, those are the ones which are indicated of usually an arterial bleed. And then most of these patients with a significant arterial bleed will have an adjoining venous bleed also, and those will benefit from pelvis packing. This is a picture, a current digital subtraction angio, which shows pelvic packing in place, and in spite of that, the patient was still bleeding, and so the angio was done, and for isolation of those.
2 minutes.
So after this brush. So this is again the intermedia. Intermedia will line up, and those are the main reasons responsible for the bleeding. These are like some of the ones which has a gel foam on the right side, and there's multiple bleeding which is picked up on angio. Again on angio, I will probably skip some of the slides because of the paucity of the time. Angio is of significance. You can do the angio if the blush is there, if the patient has CT scan showing extravasations, or even after packing, you can repeat the angio, and that is shown to be beneficial. And especially from elderly people, even if they are not showing blush, they can be hemodynamically unstable because of their physiology. They can also benefit from those significantly. Again, I mentioned all of some of them. Those are elderly patients. Okay. Definitive fixation, again, is a domain of the orthopedics. So I'm going to skip that for the paucity of the time. But there's a question about the ideal time frame when you should fix it, because we always have this pushback from the orthopedics, or this patient needs to go to the OR now. So these are the things that the patient in the extremities has to be resuscitated first. If the patient is not resuscitated properly, they will go into this lethal trial, and they will deteriorate from there. So this shows that definitive pelvic fixation should be postponed until day 4 if they are not physiologically stable enough to withstand the operation. But as you can see in this slide, the patients who are significant increase in the complication rates, which increases when the pelvic fixation is performed between
Time is over, please sum up.
D2 and D4, and decrease when it's delayed from D6 to D8. So again, this is another aspect of pelvic fracture, which is notorious for its increased mortality. This is an open pelvic fracture, but that is a discussion for another day. All right. So in summary, there are significant amounts of mortality and morbidity from pelvic fracture, and a multidisciplinary approach is the need of the time. And we need to include, we need to have early diagnosis and appropriate management, including a multidisciplinary team, including orthopedic surgeons, trauma surgeons, vascular surgeons, and intervention radiologists, and of course in an ICU center. Thank you. Appreciate that.
We will reward certificates and our gifts at the end conclusion of our session. So let me move on and introduce our next speaker, the Chairman of Surgery at Richmond University Hospital, Associate Clinical Professor of Surgery, SUNY Downstate School of Medicine. Dr. Lauren Harris is going to speak to us on when the airway breaks, challenges in tracheobronchial injury.
Okay. Thank you very much for the invitation today, and I wanted to talk to you. Many of you have not seen or have not treated significant airway injuries. Some of you have, and the good news is that these injuries are just like elective surgical injuries or elective surgical treatments of the airway. They follow the same principles. So as long as you remember that, these can be quite manageable. I have no disclosures to talk about at this time. So the majority of people with significant airway injuries still die at the scene, although we're seeing more of them now because of the change of EMS techniques. But the majority of them who die in the field die from associated injuries, not necessarily from the airway injuries themselves. The key to survival is early recognition, as in many forms of trauma, and the treatment techniques generally turn out to be fairly simple. And occasionally, we don't need to do anything for significant airway injuries, as they can be treated non-operatively with simple observation. So less than 1% of multi-trauma patients will have significant airway injuries. You see that in the neck, only about up to 6% of neck injuries will involve the airway. And in the chest, it's significantly less than that. And only about 3% of blunt chest injuries will involve the airway. Here you see how it breaks down. Blunt trauma is generally, blunt airway injuries are generally mostly in the chest, whereas penetrating injuries are mostly in the neck. And that's how it breaks down. So the good news is that penetrating injuries to the airway are generally accessible through neck incisions. So the diagnosis is basically a clinical one. You have to have a high level of suspicion anytime there is an airway injury in order to pick it up early enough to deal with it. However, many of them are left undiagnosed early on, mostly because of associated injuries and the need to treat the associated injuries first. The common symptoms and signs are what you would expect: dyspnea, respiratory distress, hoarseness, dysphonia, and stridor are probably the most common. And the physical findings include things like subcutaneous emphysema, continuous air leak in a chest tube that might be placed, as well as air leaking from a wound, like in the neck. And I'm going to present a case at the end where this wasn't the case, even though it should have been, and you'll see why. Patients who have persistent pneumothoraces or pneumomediastinum, and we're talking about large air leaks. We've all seen air leaks after pulmonary injury, and generally those seal up very quickly. And generally you only see them on expiration, not generally on inspiration. But we're talking about large air leaks here where it's throughout the respiratory cycle, where you're actually starting to think about, is there a leak in my system, not necessarily in the chest. Those are patients who have proximal airway injuries, and you have to think about that. The radiology, no one in my hospital, no one that's seen by my surgical team gets admitted to the hospital without a chest x-ray. But certainly, trauma patients should all have chest x-rays. I don't think anybody would argue against that. And what you'll see is, pneumothorax, pneumomediastinum, and you know, I get calls in the middle of the night about pneumomediastinum all the time, and they're worried about esophageal injuries. And when you have a large amount of air in the mediastinum, that's generally not from the esophagus. Most of my patients don't breathe through their esophagus, so we don't really see a lot of air there. But so those are generally airway issues, whether it's a ruptured bleb or something of that sort. But in these patients, you see large amount of pneumomediastinum and something called a fallen lung sign. And if you look at the x-ray on the left, you see that the lung has essentially fallen away from the mediastinum. That's not generally a pneumothorax. Pneumothorax, the lung falls towards the mediastinum. So when you see that, and the corresponding CT to the right there, you see that the left mainstem bronchus was actually divided, and you see the lung falls away from the chest wall and from the mediastinum as well. So that's something called the fallen lung syndrome. I've never actually seen that clinically, but it's clearly been discussed in the literature. CT scan, I mean, nobody goes through the trauma bay without getting a CT scan anymore. But CT scan can be very, very helpful. Neck and chest CT scans to help you discern injuries to the central airway. And it's much better in the neck than it is in the chest for looking at airway injuries unless it's clear. And there's something like a left mainstem disruption you'll see on CT scan. But sometimes airway injury like penetrating or membranous tears aren't as easily seen on CT scan. And but the CT scan will also help you see associated injuries because, as we know, many times the central airway injuries are associated with vascular injuries or even esophageal injuries. Those are all things you have to worry about. A negative CT does not obviate the most critical diagnostic tool for diagnosing airway injuries, and that's bronchoscopy. Every trauma surgeon should be able to wield a bronchoscope with ease, and it should not be a major issue to put a bronchoscope into somebody and take a look. And it is by far if you had one diagnostic modality to diagnose an airway injury, bronchoscopy is the one. And sometimes you may need to do a laryngoscopy as well if you're worried about a proximal injury. But for the most part, bronchoscopy is an excellent way of looking at the airway, not only to decide where the injury is, but to look for mucus and blood, which needs to be cleared from the airway to help the patient. It also can help you decide whether to not treat the patient. And it's very good for follow-up. Always use it post-treatment. So anytime a patient comes in with these types of injuries, obviously you go through your usual treatment of the patient with primary and secondary surveys. Obviously you want to rule out other injuries, but you want to secure your airway. And a lot of these patients, most of them will probably require intubation for major airway injuries. About a quarter of the cervical injuries you can actually intubate right through the injury. And that's true even if there's a complete transection of the cervical trachea. you can generally find that distal end and intubate right through it. So it shouldn't generally lead to lack of an airway. And obviously you need to assess for other life-threatening injuries. Never miss an opportunity to roll the patient, look behind, make sure there's nothing else. Regardless of what the EMS tells you the mechanism was, you have to make sure you don't miss anything else. So there are criteria for non-operative treatment, okay? And that includes small injuries, which includes less than a third or less of the circumference of the airway. This is typical of the, like you see after intubation injuries. About 12% of patients who undergo elective surgery have tracheal injuries, and the vast majority of them do not require any surgical intervention. In fact, most of the time that when I've seen them, especially with double illuminated tracheal tubes, because they're a little bit bigger, when I've seen them with double illuminated tracheal tube, you just excavate the patient at the end of the case, and most of the time they're just fine. So less than a third or less of the circumference of the trachea. Patients who are asymptomatic or minimally symptomatic, maybe they have a small air leak in the chest tube, and you basically just watch it, and a lot of times those will heal on their own. There's no associated other injuries that require surgery. Obviously, if there's a major vascular injury that requires surgery, and there's a tracheal injury, you probably should fix it while you're there. Patients who do not require positive pressure ventilation, or even if they do, a lot of times in the cervical trachea, you can position your endotracheal tube beyond the injury where that will heal up. You've all seen that in a lot of you during percutaneous tracheostomies, and you probably had a case where there was an injury to the back wall of the trachea, and a lot of times you just put your tube in and blow your balloon up distal to the injury, and in a few days you do laryngoscopy and look above, or bronchoscopy and look above where your trachea is, and it's usually healed. So many times you can get away without doing anything. So in general, once you make your diagnosis by bronchoscopy, you have to decide whether or not you can, whether you need to operate and fix it, or whether you can treat it non-operatively. And even in the non-operative patients, that doesn't mean that you say, okay, this will heal by itself, we're good, and then you just, the patient goes off somewhere in the bowels of the hospital. You have to follow those patients very closely, because occasionally, when you think that it's going to heal on its own, it doesn't. Or there becomes another, you deal with another issue where your medical or non-operative treatment fails. So you have to follow these patients, and you always repeat bronchoscopy and take another look. But in general, if there's good blood supply, it will heal. It's very similar to the esophagus. If the esophagus has good blood supply and you drained all your sepsis, the esophagus will heal. You just need to give it time. Okay, so the interventional types of treatment include stenting. You can place stents certainly in the cervical trachea, or even in the down into the beyond the main stem trachea. But a lot of times these injuries, and you have to make sure that you don't use use a covered stent. Don't ever use a bare stent, because it'll be hard to get it out. Very hard. And in fact, you can cause more damage getting it out than the patient came in with. So you have to remember that stents are not without their own complications. And many of them migrate, many of them get obstructed by mucus, and they can fracture. All kinds of things can happen. But in general, if you have a relatively stable patient and a small injury that you think needs coverage, you can place a stent, and these are actually quite easy to put in. ECMO is something to think about in patients who have severe injuries that are not immediately fixable. and they're in respiratory, they're respiratorily compromised despite being intubated. Some of them may require ECMO, but that's pretty unusual, something to think about. So the keys are to avoid tracheostomy. You don't want to perform a trach in someone who's had, certainly if you're fixing the cervical trachea, you'd rather get them extubated. If you remember, Hermes Grillo in Boston wrote multiple books and papers on the art of treating tracheal injuries and tracheal tracheal issues, tracheal resection. And one of the tenets of his teachings was, extubate the patient. You don't want a patient who's chronically intubated because that will compromise your repair. So if you can, you want to get those patients extubated as quickly as possible. And the surgical approaches, most of the penetrating injuries, like I said, are in the neck. So those can be approached via the neck, a standard neck incision. It will expose the vast majority of the cervical trachea. And you can even get down within 1 or 2 rings of the carina for the most part. If you do release maneuvers, those are things that you can do from the neck. Below the neck or beyond or close to the carina, many times it's much easier to approach these through the right chest. Vast majority of bronchial and tracheal injuries can be repaired via the right chest. The left chest is generally reserved for injuries to the distal left main stem bronchus and the bronchial branches on the left side because of the aortic arch. They're very hard to get. It's very hard to get to the carina from the arch. You're probably better off if you're not going to do a right thoracotomy. If you want to get to the carina, it's better to do it through a sternotomy. Okay, so that's not something that the vast majority of people are going to just routinely do, unless you have a good thoracic surgeon who can do that for you. Okay, so the main principles of tracheal resection are those of knowing the blood supply and keeping your trachea or your bronchial portions that are injured being resected, maintaining the blood supply. In the cervical trachea, the blood supply mainly comes from small lateral branches from the inferior thyroid artery. So you want to minimize dissection. Okay, this is not cancer. You're not dealing with cancer. You don't need margins. All you want to do is get rid of any devascularized tissue and mobilize the trachea to minimize tension on your anastomosis. If you do those two things, it will heal. Okay, and it will be successful. So you want to do minimal lateral dissection around the trachea. You want to do most of your mobilization anterior and posteriorly. And if you need to, you can do, there are various release maneuvers that will mobilize the trachea without lateral dissection. Okay, so this is basically what I just said. And we use absorbable sutures, and again, it doesn't matter whether the knots are on the inside or the outside. These are absorbable sutures. We used to argue about that all the time. But we used to use Prolene for this. You want to make sure that all your knots are on the outside. It doesn't matter anymore because we use absorbable sutures, and no one develops these granulomas around the knots anymore. Again, tension is your enemy, just like for vascular anastomoses. We do use vascular flaps generally in the neck. You can just take a strap muscle and put it over it and close it in layers, and those generally do very well. In the chest, we use vascular pedicles of either intercostal muscle. You can use pleura. On the left side, I've used pericardium. There are all kinds of things you can do. Okay, and make sure you suture the chin to the chest. I always suture the chin to the chest, and that's just generally because when you flex your neck, the trachea goes down into the cervical trachea goes down. So that will minimize trauma. And of course, you do bronchoscopy a few days afterwards to make sure that everything's healing well. So this is kind of what it looks like. You can do it running, you can do it interrupted. The trachea doesn't matter. If you can stand there and hold it together with your hands for a week, it'll heal. Okay? So you can do it any way you like, but you just have to follow those main principles. We had a patient who attempted suicide by slashing his own throat. He was stable on admission. He had an obvious slash wound to his neck. He actually did a very nice job. Was intubated orally, and they were able to intubate him orally. And we saw, and this is what we saw. The head is to the left of the screen, and he basically had a 2/3 transection of his cervical trachea. You can see the endotracheal tube there. And this was actually very simple to fix. We exposed it. We used fluorovital interrupted sutures. I didn't let the resident do the whole thing. It's really not that difficult. And I did the EGD on the table just to make sure, just to rule out any possible injuries, and close the wound in layers. This is what it looked like. And he did remain intubated overnight because we were worried about swelling. And we gave him Decadron, racemic epi, because it was very close to the thyroid cartilage, and we weren't sure if he had bagged the superior laryngeal nerve. So, and then this is what it looked like about a month later when I brought him, very nicely healed. So for the most part, the cervical trachea is a very good actor, and tracheal bronchial injuries are very uncommon, but can be quite lethal. They require a high degree of suspicion. You have to suspect them. And then don't forget about bronchoscopy. Bronchoscopy is essential for this, not only for making the diagnosis, but for deciding what to do, and ultimately for following the patient. And just remember, not everybody has to have surgical repair. And for the patients requiring the surgery, the basic principles of tracheal airway surgery apply all the time. So if you follow those general principles, these are these patients do quite well. Thank you very much.
Thank you very much. It's my pleasure now to invite Dr. Julie Valenzuela, Assistant Professor of Surgery, Division of Trauma, Surgical Critical Care and Burns, David Doherty Family Department of Surgery, University of Miami, Miller School of Medicine, Medical Director, Ryder Trauma Center, Jackson Memorial Health, speaking on transforming delivery of trauma care, integrating trauma-informed care approach in the resuscitation bay and beyond. Dr. Valenzuela.
Thank you. Good afternoon. Thank you for having me. Again, I'm Julie Valenzuela, trauma surgeon and the medical director of our hospital-based violence intervention program, or ACUTE, in Miami. And today I'll be sharing how trauma-informed care and ACUTE can reshape our surgical response to violence, not just in the trauma bay, but across healthcare, community, and law enforcement systems. This is Vita. He was 16 years old when he was shot and left paralyzed. He had no real support system, no clear path to recovery, and no roadmap to how to rebuild his life. Now, Donovan came with a pretty simple hemothorax, clinically a very straightforward case. He was discharged home within a few days. Unfortunately, right back into the neighborhood where his gang members were waiting. These stories are not unique. They highlight how we treat the injury, but often miss the context, the risk, the environment, the trauma that brought them to us. Today we'll discuss the public health impact of gun violence, define the role and structure of ACUTE, and explore trauma-informed care and surgical practice, and share strategies for cross-sector collaboration. Dr. Peter Rhee already went over the sobering statistic that gun violence is now the leading cause of death among our youth. It's costing us over $550 billion annually, encompassing healthcare, legal, and lost productivity. But these numbers also reflect something less measurable, a profound ongoing community loss. Now, gun violence has been shown to behave like infectious disease. It clusters, it spreads, and it transmits. And if we agree that it's a public health crisis, then it demands the same principles: early detection, timely intervention, and credible messengers. Now, before we talk solutions, let's consider where trauma begins. This is a visual of adverse childhood experiences, or ACEs, things like abuse, neglect, or witnessing violence. And ACEs aren't just personal, they can happen on the community level, war, natural disasters, or forced displacement. And ACEs are linked to poor health outcomes, early mortality, and chronic disease. 2/3 of the population report at least one ACE. 1 in 8 report 4 or more. And health outcomes worsen in a greater fashion as the number of ACEs increases. So the trauma we treat surgically often start long before that injury. And these experiences are now what we understand as the social drivers or determinants of health, shaping behavior, risk, and outcomes long before those patients reach their trauma day. So, how do we intervene, upstream and downstream? And that's where community violence intervention, or CVI, comes in. CVI identifies those at highest risk and surrounds them with credible messengers, wraparound services, and ongoing support. These are multidisciplinary partnerships involving healthcare and community stakeholders. It is a public health model grounded in trust and relationship-based care. Because after traumatic injury, we have this rare window of opportunity, and it's not just about clinical care. It's a moment to connect. We need to shift our conversation from what's wrong with you to what happened to you. It allows the door to open for strength-based healing and long-term engagement. Trauma-informed care promotes safety, trust, empowerment, and collaboration, and it's rooted in what we see the 4 R's: realizing the widespread impact of trauma and its prevalence, respond in ways that support recovery, and recognize the signs. How often have we labeled someone as non-compliant, agitated, when they're actually scared, hypervigilant, overwhelmed, or perhaps withdrawn, and resist re-traumatization through conscious patient-centered care? Because at the trauma bay, we can unintentionally cause harm. We're stripping patients, rushing procedures, crowding rooms, and think about how often we say things like, you're going to feel some pressure on your bottom. Now that's a woefully inadequate explanation of why we do rectal exams. I had a patient, a male survivor of gun violence, who had a history of sexual child abuse. Now, I did not have time to get that history in the trauma day. So our language matters. So instead of vague or clinical shorthand, what if we said, I'm concerned about potential rectal injury based on your wounds, and that might impact our surgery. Would it be okay to get a rectal exam to check? I tell my students, assume all patients have a trauma history and approach care the way we use PPE as universal precautions. Because without context or consent, even well-intentioned care can deepen trauma. So in Miami-Dade County, our CVI ecosystem includes our Cleveland Trauma Center, Private Trauma Center, community-based case managers, credible messengers, law enforcement, and faith-based organizations. And we're operating with a shared goal, real-time communication, and a commitment for long-term follow-up. And our multi-pronged approach addresses both upstream and downstream risk. We're reaching individuals who have already been injured, we're reaching those for future harm, and those navigating the legal system involvement. And our HFIP is just one component of our broader CVI programming. Again, we're identifying high-risk patients at admission, offering support at the bedside, and engaging in longitudinal care after discharge. And that care often continues for months or even years, extending to families and communities well beyond the hospital walls. Our clients are primarily young, Black, uninsured, and disproportionately impacted by structural inequities. Initial needs are primarily financial, wage loss, medical bills, relocation, burial, rental costs. And we're finding that our clients in particular, that mental health is accepted later, once safety and stability are in place. And our mantra has been, meet people where they are and walk with them as they heal. One of our most effective team members is what we call a secret weapon, our HVAC nurse. He is an ICU nurse and also has training in mental health, who works independently, visiting clients in their homes and communities. He bridges clinical care, wound care, advocacy, and counseling. He is quite literally equity in action, a young Black clinician from South Florida offering a level of cultural and clinical competency rarely seen in home-based care. Now, our literature review found that trauma-informed care in surgery is rarely implemented or studied. There's a growing body of evidence in OBGYN, pediatrics, psych, but we are behind in acute care surgery. So what are we doing? We're embedding trauma-informed care in our medical education, our discharge workflows, and system policy. Our next step, training law enforcement. Through our ACUTE and our partnership with Circle of Brotherhood, that's a grassroots street outreach group, we're co-developing a trauma-informed care curriculum for new cadets who will be the future police officers. And on top of that, we're working with currently incarcerated mentors. That's a positive peer leadership mentoring program that we have to co-lead this training. Trauma-informed care is not soft science. It's foundational to safety, dignity, and recovery, and essential for long-term violence prevention. And I'm also thrilled to share that trauma-informed care will be included in the next upcoming edition of our ATLS. Here's your trauma-informed care checklist for surgeons. It's simple, actionable, team-based. Use it to change that patient experience one interaction at a time. Our goal is to build trauma-informed systems that connect medicine, community, and public safety. And we're seeing real impact in Miami-Dade County. Vito and Donovan, they're not only alive, but they're thriving, and thanks to coordinated care and community support. It hasn't been easy, but I believe without this approach, their outcomes could have been tragically different. Thank you for your time.
Thank you very much. We'd like to get time for questions. We've caught up on time. We have about 20 minutes, so